today. I know we're all very busy. It seems to happen in the fall. So I appreciate you taking the time to stop and think a little bit about this special population that you are serving. So just a tiny little bit about the Oregon Primary Care Association. We are the association for all of the federally qualified health centers in Oregon, plus one from Idaho and one from Washington that operate clinics in our state. And we provide technical assistance to all of you. And we also learn, educate, and influence health policy at the state and national level. Our mission is to lead the transformation of primary care to achieve health equity for all. And what rings true to me here is that in the pursuit of health equity, we need to pay attention to our special and vulnerable populations that we serve. And so we have been offering this Special and Vulnerable Populations webinar series. If you haven't been able to join us yet this year, we have done a webinar around language access and the needs and now requirements for training of your interpreters. We've done some around HIV and AIDS care and the providers for that kind of technical assistance and care in the state. We had a great webinar on LGBTQ health, working with the national cooperative, the Fenway Institute, and hearing from someone from the Outside In clinic here in Portland about transgendered care. That was a very enlightening and interesting presentation. And then our most recent webinar was around food insecurity and partnerships that you can engage in with the Oregon Food Bank to support healthy food coming to your clients. So today we are going to be talking a little bit about homelessness. We decided to focus in on the rural homeless because there's a lot less information out there about this group. And then the very last webinar we'll be doing is around migrant seasonal farm workers. So as we've done these webinars, we've also been collecting the names of you who have been participating or at least interested in participating so that we now have some email lists for all of you who want to get further information about any of these subjects. So if you or any of your colleagues you know of think you would benefit from being on this Special and Vulnerable Populations email list, please let us know and we'll get you signed up. So one thing that I want to share with you, I don't know where that one didn't show. We will not, after this year, we're not going to be doing a webinar series next year, but there are a number of conferences that are actually coming to Portland this spring that I wanted to highlight for you. There will be the Western Forum for Migrant and Community Health at the end of February here in Portland. And then later in May, there will be the National Farm Worker Conference. And then, for some reason, it's not showing up on my slides, but there is also the Healthcare for the Homeless Conference, which will be taking place at the end of May, also here in Portland. And that is the big homeless conference for nationally. And they are blessing us with their presence here in Portland next year. So those are some great learning opportunities that we encourage all of you to attend if those are your areas of focus. And we will get all of these slides out to you with that information so that you can find out more about those conferences. All right, well, to talk a little bit about today, just so you are aware, I'm going to back up a moment, feel free to send chats through the chat box as we go along. We'll be monitoring that. Particularly during Dr. Guthrie's presentation, you can send in chats and we will we'll let her know. We'll kind of break in if the question is pretty relevant to the current conversation, or we will address it as we get to the end of the call and take questions, open it up for a little more general questions at the end. All right, so today's learning objectives are to understand some of the common characteristics and challenges of the rural homeless, to learn how to use clinic and community data to determine what or if health disparities exist for this population, to consider medical and social interventions that you could design or partner to create to meet the needs of the population, and to learn a little bit about the Housing First model. And Dr. Libby Guthrie will be sharing some more information with us about that. So those are today's learning objectives. And we'll just launch right in. So, you know, the first question we sort of had, we have a team here, our Special and Vulnerable Populations team. Alicia and Akira and Stephanie and I are part of this team. And we thought a little bit about what does rural and homeless look like. I actually had a bit of a hard time going and finding information. The majority of the homeless population does live in urban areas. And you can see some information here from the National Alliance to End Homelessness, their estimates, and it is always kind of estimates with homeless populations because we don't always get great counts, is that in rural areas there's about 14 homeless people for every 10,000, and in urban 29. So just about double in the urban areas, but it looks like even less when you look at the overall statistics for homelessness. I've seen figures that it's actually maybe only 7 to 10% of homeless individuals are in rural areas. Some of that may be because it's harder for us to actually track and find people that are homeless when they are in rural areas. Some of the things to think about is that there is more poverty in rural areas, so people tend to be more at risk for homelessness, particularly if there is some sort of industry or thing that's driving up rental costs in the area. There's more homeless families as opposed to individuals living in rural areas, and often homelessness looks like someone doubling up in housing with other individuals. So it's not necessarily people out on the streets or in tents, but definitely crashing on couches in someone else's home, extended family, all living with in one household. And it makes it tricky to get accurate counts when people are doubled up, or and the other piece being homeless camps in rural areas are harder to find. You know, here in the urban area like Portland, I can see them over the edge of, you know, the highway bridge. I can see where tents are popping up. We can see where people are sleeping on the streets. In rural areas, there's a lot more territory, and it's a lot harder to know where folks are going and sleeping because there's a lot more forests or open spaces that we can't see. So that's some very general information about the rural homeless. Did we go back one? Oh, hang on. Let me see. Oops. Yeah, never mind. All right. So we did pull a little bit of information from our UDS data on the homeless numbers for the Oregon clinics, and I'm going to let Akira talk a little bit about that.
Thanks. So I'll just be presenting a little bit of data that we got from UDS. Just a couple notes. This is from UDS 2014, so this is about a year old, and this is data that has been pulled based on how UDS is defining the clinic. So in other words, if the clinic had come up to, you know, got grant funding and reported to UDS when they started, you know, in 2009 or something, if they were a rural clinic then, that has carried over until this year. So just keep those kind of caveats in mind as we're talking about this data. On this particular slide, you can see a trend of homeless by type. So we have rural, urban, and then for all of Oregon. And so you could see kind of over time that the total of urban homelessness is trending downward, as well as the total of Oregon homelessness is trending downward, whereas the rural homelessness appears to be trending upwards. And so that kind of just begs the question as to, are more clinics popping up that are just reporting this data to UDS and we just have more data on it than we used to, or is there actually an increase in rural homelessness? And the other thing that's interesting is that you can see in 2012, all of these three categories experienced a dip. And so that kind of makes you think about what was going on in that year that would cause you know, rural or homelessness in Oregon to decrease and then bounce back up the next year. Next slide. And then this slide, it kind of gives you an overview of where in Oregon some of this homelessness is coming from. So kind of to Claire's point, you can see that Claire's point earlier about, maybe half less homeless, half the amount of homelessness in rural areas versus urban areas. You can kind of see that on this graph or on this image. So for example, the Willamette Valley region has 12% urban homelessness, where some of the rural areas, such as Eastern region and Coastal region, have about 6%. And then you can see the Southern region, which is also very interesting, that there's about 2.37% rural homelessness, but they also have reported a large percentage of urban homelessness. So some of this begs to question the actual definition of rural versus urban homelessness and how the clinics are defining it, how UDS or HRSA is defining it. But I like this image just because it shows you kind of where this rural homelessness is coming from and how many clinics in that area are serving that population.
Oh, thank you. Any quick questions about this UDS data and what we've shown you on the graph and this map? And Stephanie, will you unmute folks for a moment?
And I will add just one more thing, that there are actually a couple clinics that have been excluded from this data, and that's because they were, UDS was reporting them as mixed, so it was hard to tell whether their homelessness was actually rural or urban, so they're actually excluded, but all the other ones were actually identified as either urban or rural.
And another thing that we do know about you guys as you serve these folks is that some of you get special funding for serving homeless populations, and some of you don't, and it doesn't actually seem to correlate to the number of homeless you're serving. So, for instance, Lincoln County, who we will have talk a little bit later, don't believe they get funding for homeless clients specifically, but they actually had almost 10% of their patient users identified as homeless. So for those of you who don't get special funding, I think it's particularly important to think about if there are programs that you want to think about creating for this population if they are hitting a certain threshold of individuals that you're seeing. 10% is a good percentage of your clients, and I think worthy of creating some sort of a program if you feel the need. So let's go to the next slide. What we did try to do is find out if there's any good kind of community-based data on homeless counts in rural areas. And there is one source that we came up with from 2011. And I think all of you know that sometimes the data we're looking at is not quite as timely as we wish, but it is the data that we have. I went in and looked at this data for a couple of different counties. Particularly, I went and looked at Lincoln County and discovered that these are point-in-time counts, that Lincoln counties must have been way undercounted because there was actually, will you go on that, Stephanie, and show us? So showing very few homeless individuals and households in comparison to other counties on the coast. And so while this data does exist, you definitely need to take it with a grain of salt and think about who you're actually seeing and identifying through your own clinic UDS, and if that is looking at all like the information that's out there. I had a great conversation with our presenter, Dr. Libby Guthrie, about the data that we collect on homeless individuals and how difficult it really is to get accurate numbers and an understanding of these numbers. And maybe she'll talk about this in a little bit, but her organization was actually working with a number of other local organizations where they were sharing information on the homeless so that they could get a much more rounded picture and count of all the homeless folks, because any one organization was not really getting that picture very well.
Claire, it looks like we have a question here from Monica Alexander. She asked, When will 2015 PIT be released?
So the point in time counts. That is a great question, and we will have to find out. We'll let you know. We'll try to figure that one out, and when we send out some follow-up information to this webinar, we will let you know. All right, so let's come back out of here. So, wait, can you go back one more? All right, great. So, I wanted to find out a little bit from you guys, and we'll start out with Lincoln County, about how you currently look at your own data and potentially compare that to community data. But how do some of you pull your data in order to understand a specific population segment? We talk a lot here at OPCA about segmenting our populations, and many of you do that on disease-specific, for diseases, like your diabetes registry is a segment of your population. I don't see as much of that happening around demographic factors like whether you're homeless or whether you are maybe elderly or you know, those certain demographics, and if your outcomes look different based on that. So Val at Lincoln County, can you share a little bit with how it was for you to go and try to find data on your homeless and what you learned in that process?
Sure. So I was asked to get into our electronic medical record and see if I could just easily pull some data for our homeless population. And before I go on further to that, maybe I didn't tell you this, Claire, when we were first talking about we have a homeless program in Lincoln County called HELP, Homeless Education and Literacy Project, and they track all of the homeless data for the kids in schools. So we get a lot. We do have access to data for students, and there's a really strong program here to help connect those students to services, including our 4 school-based health centers. But in terms of the rest of our patient population, I was asked to sort of dig into our data and see what I could find. And I didn't get very far, partly because we don't have, we use OCHIN and we don't have an official report writer. And thanks to Claire asking about this project, I've now been assigned to become a report writer. So maybe next year I'll have more to report on. But it was very frustrating to try to dig in and use the reporting system that OCHIN currently has set up for just your everyday average Joe computer user. And I was able to pull some data, but it really didn't tell me you know, how long the person had been homeless, because for UDS, for them to fall into that bucket, my understanding is they just have to be listed as homeless once during the measurement year. So it just started bringing up more questions about, you know, how long has this person been homeless if they were marked homeless within the measurement year. And so I guess in summary, I just kind of came back and said it's a good path to go down to try to find out what your homeless population really looks like. But I think identifying what you're actually wanting to do with the data and what data you're wanting to pull out is necessary in order to start building these reports.
Yeah, well, thank you so much for sharing. You know, and there's a few things that I'd heard from you sort of as you went through the process, and one of them was the question of, well, am I looking back over a time period at homeless folks, or do I do a kind of a point-in-time report because the homeless status changes? And so how do you know if they're currently still homeless or, yeah, so
right,
deciding.
Right. And if they are, what is the average length of time that they're homeless? And then again, what you talked about earlier was the different categories of homelessness. That, you know, we have a lot of those couch surfing students that are considered homeless because of that, or they might run away one day and, you know, for a short period of time, and then they're caught in the system. They come in for a visit and they say they're homeless. So it's and different agencies like this one I talked about have different definitions for homeless than what UDS has. So I think there's just still a lot more to dig into and learn about to be able to better serve this population.
Yeah, and then the one other thing too that I had sort of noticed as you were looking at this data is that Lincoln County is an FQHC, and your mental health program is underneath your FQHC umbrella, and so you're also thinking that a number of your homeless folks who are entering your program through the mental health resources as opposed to the kind of primary care physical health side of things. So that also just made it a little more interesting to try to figure out who they were and how they're receiving services from you.
Right, right.
Yeah.
So we ended up with more questions than answers.
Definitely.
And no report.
But it sounds like soon you might be able to run that report just the way you want.
Yep.
And then, you know, I know for those of you that are on OCHA and EPIC, we are sort of coming up with the, or not coming up with, OCHA has been working on the Acure system, which is something that is pulling in a lot of community data too. And so when that is up and running, that might actually be really the right kind of place to try to get some data on your homeless clients and how they compare in relation to the rest of the homeless population in your community and your community at large.
Right, and that system, from my understanding, is built on the NQF metric definitions. So it's a slightly different. We're having trouble using it as we're looking at our clinic from a UDS perspective. We're just having trouble using that system for our needs.
Yeah. You know, I did have a quick question here about, did we actually go and define what the rural homeless definition is for UDS? I can run through that really quickly here. I've got it in front of me, and then we will also send that out to folks. But according to HRSA, homeless individuals mean an individual who lacks housing without regard to whether the individual is a member of a family, including an individual whose primary residence during the night is a supervised public or private facility that provides temporary living accommodations, and an individual who is resident in traditional housing.
Transitional
housing. That makes more sense. So that is the UDS definition, and I think it is worth noting that, and then seeing if you are working with other homeless organizations in your local area, do they have the same definition, or are they working off something that's a little bit different, just so that you understand the nuances. All right. So I was hoping to just find out from any other clinics on the line if any of you kind of pull data just for your homeless populations, and if so, compare health outcomes or do anything special with that population segment. Anybody willing to share how they use data?
Hi, Claire. This is Linda Maxon calling.
Hello.
Hi. So we are just on the front end of starting to pull data. We certainly have the fields. We're in eClinicalWorks, so a little bit different, and we are inputting the demographical information so that we can start to pull data. So we do not actually have access or information entered as to where the homeless are located, or their residence or type of residence that they have, and but we do have fields that we're working with our software vendor to be able to put in more details on homeless so that we can start to track that along with the health outcomes specific to the homeless population.
Great. Well, I look forward to hearing how that works out. And that it's nice that you're starting and sort of designing it the way you want it to look, too. Great. Anybody else want to share how they currently pull data and use it? All right. Well, I'm going to go ahead and move us on because we have a lot of great information coming to us next. And one moment here. Oh, sorry, I skipped a quick slide. So what's the point of actually pulling data? You know, we don't do it just for fun, but we do it so that we can get a better picture of the folks that we're serving and understand the way that I was thinking about this, in particular, pulling your homeless population data is perhaps you would want to compare the health outcomes for a particular indicator such as diabetic care and see if the health outcomes for your homeless population look different than for the rest of your clinic population. Because, well, I mean, there's a very good chance that it will look different, and if it does look different enough, then you might want to consider some kind of intervention for that group or a special program. Maybe you'll hire a community health worker that goes out and works with this population, or maybe you will find a place where they currently engage in your programs and you can get them at that point. For instance, using mental health services, maybe that's a good place where you could come, and when they have an appointment to come in for some mental health services, then you could also try to connect with them around primary care services. So really just be thinking as you look at the data, you're looking at it to give yourself a part of the picture, and then you need to think about these other things about how do you currently engage with these patients, what other natural allies and resources are out there in your community for them already, and what is it you actually want to help them with. So is it really about improving their diabetic care, or do you want to help them think about how to get into housing? So there are different ways you would want to address working with them depending on what the goal is of what you want to help them accomplish. All right, and now I'm going to go ahead because I want to give plenty of time to Dr. Libby Guthrie. She is the Executive Director at the Mendocino County. I don't even know that. I have the acronym spelled out later on. But she has been working with this population in a large rural area for a long time, and has agreed to share her kind of knowledge and expertise and journey with us over the next half hour. So, Libby, are you on the line?
I am.
Great.
Can you all hear?
Well, thank you. Yep, we can hear you, and thank you so much for joining us.
Okay. Well, thank you for having me. I really appreciate it. There's a whole lot to talk about. I didn't even know how to whittle it down, so I'll do my best within the time constraints. So
thank you.
I'm from, and that I work in is an extremely large, mostly rural county in Northern California, 3,500 square miles, really rugged area. It's really hard to navigate, and we have mountains between the inland part and the coast, and dirt roads and one lanes, and anybody that's been to Mendocino County and traveled around probably knows what I'm talking about. Sometimes the services for people are quite literally 2.5 hours away. So if they were to come into the center of the county and had adequate transportation, it could take that long to get here. The mentality, if you will, I say renegade mentality because we are part of the Emerald Triangle. We had a mass migration from cities in the late 60s and early 70s, so the population is very, very mixed here. People with a very wide range of ideas and our injection drug use is higher in this county than all but 4 other counties in California. And up to 90% of our people who inject drugs have already been exposed to Hep C, so we have a very large problem with that going on. 39.7% of the county live below self-sufficiency standard, and that's 8 points, almost 9 points higher than California's overall average. 20% of the singles live below poverty level, and our county jail is completely overwhelmed. And as many of you know, the jail system is very crowded with people with co-occurring disorders and single diagnosis of mental illness and co-occurring disorders. And our rate of homelessness in the 2007 point in time count was second only to the city of Detroit, Michigan per capita, which was really a surprise to us, even though we see it on a daily basis. So next slide, please. Our agency started out as a volunteer agency in the mid-'80s, and we specifically took care of people who were actually, you know, dying. And we had a very, very focused kind of support agency, buddies, healthcare workers, people that could do practical supports for people at the end of life. And in the early 90s, like other AIDS service agencies all over the United States, we were able to access Ryan White CARE Act funds and establish more focused case management, and we had funds to do to provide a lot of advocacy, food, transportation, a lot of supportive services that we don't anymore. We're also a HOPWA, or Housing Opportunities for Persons with AIDS agency, and have been that agency in the county since. We morphed, and I'll talk a little bit about that later, but we morphed into prevention services and became very harm reduction focused back in the mid-'90s to the late 90s. And that's where we kind of embarked on a larger journey. Next slide, please. So our first care coordination services were under the Title II, what's now called Part B, and we did that in coordination with the Medi-Cal AIDS Medi-Cal waiver and what used to be called the AIDS Case Management Program in California. So we've had the opportunity to be kind of have a team approach, at least in the area of HIV/AIDS, for 2.5 decades. Just really because being rural, the pool of people that worked within this paradigm were a small group, 20 to 25 people, and got to have very, very long-lasting relationships. We continue with advocacy and interface with medical and psychosocial service providers, and the medical provider in our community that does the HIV, the Part C of Ryan White, is right here in our in the center of the county. But again, that could mean if somebody needs HIV care and they live 2.5 hours away, they need to get to the clinic here in town, or they need to get to one of the satellite clinics that maybe cuts off 15 miles of that trip. And we established ourselves as you know, as a benefits counseling agency as well, and put people through SSDI and SSI applications and represented them. Next slide, please. So So when we started doing our outreach efforts, prevention efforts, we got some grants in the very early 2000s that were outreach for HIV grants that we got through the California State Office of AIDS, but we found such a very high percentage of hepatitis C in our community and so many people that were very ill and had very similar needs to our HIV positive population, that we looked for funding and resources and relationships and partnerships that would help us establish care and an actual care coordination plan for people with Hep C. So over the years, we've funded that in a variety of creative ways, educational grants, specific case management grants, and just did our best to piece things together when we had no grants, keeping relationships and keeping them strong with our local FQHC, which is also our Part C clinic. And the way that we have really kept those connections is not only through our HIV care, but through consistent referrals from our syringe exchange program, which we have in-house and out in the field here, and our testing services. And we were without HIV testing for about 6 years until just within the last year we've been able to get funding for that again. And we've continued to do hepatitis C testing services over the last 10 or 12 years. So one of the overarching, conditions for many of our clients starts with homelessness. And, a percentage of our HIV positive folks start service as homeless, and people with Hep C, and people who come into our syringe exchange who have co-occurring disorders. One of the other comorbid conditions is always homelessness. And I was struck by the slide that said 14 out of every 10,000 the population in most rural areas. I did the count based on last several point-in-time counts. In our county, 126 in every 10,000 are homeless. So 126. That was, when I saw the slide for 14, I was struck by that. So we have obviously some situations that are unique to this county, some that we understand and some that we probably don't so well. Next slide, please.
What? Close to it, but no.
Pardon? Okay. So our agency provides practical assistance so people find connection and incentive just to, for basic needs, food vouchers, transportation services, benefits, alcohol and drug counseling, and harm reduction counseling, which is really at the crux of the services we do for people who have co-occurring disorders. We, obviously being the kind of agency we are, we don't require a sobriety, and we don't require people to be in service to access our services. We just take people as they are, and that's a really, really important way that we've been able to engage homeless people, mentally ill, those with co-occurring disorders over the past 28 years, is that open house, if you will. And we kind of had a natural, if you will, connection to Shelter Plus Care, or permanent supportive housing, as they call it now, because our HIV positive clients had kind of a, I don't know if you'd call it a carve-out, but because it was a priority for housing for so long, we were able to fast-track some of our HIV-positive people into kind of a housing-first paradigm before before HUD actually called it that. Because of their inability often to be able to manage taking antiretrovirals and being able to care for themselves when they were having horrible side effects, and so it was a somewhat streamlined way to get our folks into housing who were positive. Our continuum of care here several years ago made a decision to make all clients who were going into shelter plus care housing meet the clean and sober and jump through a lot of hoops criteria, and that changed a lot of things for our clients for several years. Anyway, next slide, please. Thank you. So we've been, this agency has adapted to populations instead of restricting itself to HIV positive people, and because there's so many comorbidities on board, we really started looking at how we could attend to the needs and coordinate the care for people who had several comorbidities. And of course, then we were able to access funding from different resources: mental health, substance use, HIV, hepatitis C, and homeless services. And we expanded our mission overall to serve people with, not restrict our services, but to be more open about access to any one of our programs, so there isn't any wrong door even within the agency. And if there is, then we have connections with the referrals that we need to make for that individual. So we had a very high rate of contact with the criminal justice system because so many of our clients also had criminal justice issues on board, and that actually built relationships with providers in town, public defenders, DAs, and built our relationships with people so that we made kind of a metamorphosis to also doing like behavioral health court, working in recidivism reduction, because we already had a natural population in all of these programs that were criminally justice involved. And that actually helped us make connections in the community. So it's been interesting to watch how each, if you silo or if you look at conditions and infectious diseases and legal issues in silos instead of holistically, you might not build those relationships, but we've ended up with a very wide variety of support systems in the community. Next slide, please. So again, about the metamorphosis. When we first started being more than a care management agency for people with HIV and AIDS, we, our community health outreach workers were all over the county, and they had the ability to see a lot of the other comorbid conditions. They were able to bring people into services. That was a funding source we had in California, 12, 15 years ago, also private foundation funding that helped us continue that. And then things pretty much dried up in 2009 in our community, and we had to do a lot of work with volunteers, entirely volunteers, and that really changed a lot of our services. As part of our metamorphosis, if you will, we started implementing an underground syringe exchange in 1998, and later in 2000 we were able to establish ourselves as an authorized syringe exchange. That was something that until the state of California made decisions about allowing syringe exchanges to be present in counties that hadn't necessarily authorized them, we did have a county board of supervisors that authorized every 2 weeks for several years for us to continue as a way to minimize the public health threat of HIV and hepatitis C. And next slide, please. I already talked about the housing first kind of paradigm that we were trying to work in years ago for our HIV positive clients. We could not do that with hepatitis C clients, but because they were very fragile and many of them also severe mental health challenges, it actually helped us to be able to get people fast-tracked into housing, a shelter plus care program. And because we had the history of being a HOPWA provider, we had some experience already in connecting people to housing, helping people maintain housing in a variety of ways. And we it was just a natural adaptation was that people continued to come in off the streets and say, I hear you guys help with housing. And we were, well, yes, we do, but that's limited to people with HIV. So over several years, we made some significant breakthroughs with some of the agencies in town here who started to see us as more than the AIDS Service Agency and were somewhat open to our getting other fragile individuals housed as quickly as possible. Next slide, please. So the housing ready paradigm is really what's been going on for a very, very, very long time. That just is, clean time, compliance with rules and restrictions, and a very specified period of time before you'll get housed. You're told the circumstances under which you will be passed the test, if you will, and that you will be able to be housed. Next slide. In the housing first paradigm, the HUD, is accepting of that paradigm and is actually pushing it at this point in the United States, and it's just seen as home as constancy. Day-to-day routine of human existence is housing, control over one's life and free of surveillance, not living on the streets and feeling completely out of control of your life and any health conditions you may have. And that home is a secure base where identities are constructed. And for those of you that know about Housing First or know about that homelessness is considered a comorbidity in itself, the idea of having housing underlying everything else that you might begin to try to accomplish, it's the very first bottom line. So our agency is now, we are be the operator of an emergency homeless shelter for the next 4 months. We've been working a whole year with many community partners to do that, and it looks like we're actually going to be able to open it November 15th. And one of the tools that we'll be using there is one that is pretty much required by all continuum of cares all over the United States, is to have a coordinated assessment process, if you will. And one of those pieces that's really vital is the vulnerability index. And it's really looking at acuity and what 15 dimensions that determine the acuity score, and will fast track those who are the most vulnerable instead of utilizing the who's ready, willing, and completely able to step into this housing and be successful. Instead, you're flipping the paradigm and you're saying who is the least able to jump through those hoops and gain access to housing. Instead, you look at the highest vulnerability score and you place people in housing based on that score. Next slide, please. The people who will benefit most from Housing First, from using the vulnerability index, are people who need Housing First. It will also actually, I don't want to use the term screen out, but it will place in a different category people who are most likely to end their own homelessness with little or no intervention, so that the focus can really be on people who struggle day in and day out, year after year after year, with chronic homelessness, and address the issues that continue that chronic homelessness and continue the circumstances under which that continues. And then how individuals and families are changing over time. So you use this vulnerability scale, you reassess over time to see how things have changed, what kinds of progress has been made. And it really covers different domains like risk, history of housing and homelessness, a person's socialization and daily functioning, it also their overall wellness, and over time you can gather this personal information, data if you will, and see what kind of progress is being made, and actually support that person by being able to show them what they've accomplished in the time that they've just been housed. So it's an exciting thing. Well, why this population? Complex, co-occurring conditions. Most of our folks, no matter what program they're in within our agency, and we do have a program for Hep C, we have a program for HIV, we have a program for high recidivism and reducing recidivism, and we also do a behavioral health court, case management for our local behavioral health court. And most people have several comorbidities and conditions that make them more vulnerable. We have high blood pressure and diabetes and liver disease and heart disease and all of these things on board at once. So instead of, again, separating out all these conditions, our purpose is to consistently bring people into services, make referrals, follow that person into services, monitor those services, and support positive outcomes. So it's not enough to refer. It's extremely important to stay by the side of that individual until they are completely established and can make it on their own and are getting the proper care that they need. So we had a program about 5 years ago that was actually financed by our county medical service system through the state of California, and that was to address the needs of high utilizers. And I know you've all heard of high utilizers, and we're a county that had a very high utilizer population using crisis-oriented, very high-cost services, a lot of emergency room admissions. One of our first clients in that pilot project had 92 ER visits in 1 year. And during the year that she was in our program, we got that down to 12, which was pretty amazing. So in all of our programs, we look at how we can engage at the simplest level, how we can build on that engagement, how we can guide, how we can support, how we can actually, you know, help somebody implement changes and help them with consistency in all things that are medical, housing related, and all the other major domains. Next slide, please.
Libby. Hey, Libby, this is Claire. So, you know, I am realizing I did not give you enough time to cover everything. We're about down to the last 5 minutes. You've made it through a lot of... Yeah, so here's my quick thought. You know, you have a bunch of information on the comprehensive assessment tool that I think we can just send the slides out for, because that's pretty, it seems relatively self-explanatory.
Yes.
I was wondering if you wanted to just sort of wrap kind of up this piece and then see if there's any big questions from the group. Would that work out all right?
Wrapping up.
Sorry.
What's that very next slide? Is it the comprehensive assessment? I can't
it's all, yeah. There's the common risks, and then we go into that comprehensive assessment, yeah.
This is one thing I want to say. I really, and I didn't really get to talk about it, is I know this slide here is super important to me because the very next one, about CUSOC and ROSOC, because we were able over time, and we are definitely the redheaded stepchild of the community because of what we do and who we serve, but we were able through that one first grant that was collaborative with the hospital, the FQHC, Alcohol and Drug Treatment Center, County Sheriff's Department, and us. And we teamed together, and that has spawned, if you will, half a dozen county-wide collaborations since that time. So I find that you can find those connections by looking in many, many directions and continuing to keep those connections with the most important providers in the community. So thank you.
Libby, I'm just wondering, are you able to stay on the line a little past the 2 o'clock hour? Great. So those of you who are able, we can stay on and do some questions and answers now. I know some of you will have to run off to other meetings, but this is being recorded, so if you want to catch some of this later, we will have that recording available to you. And let's just go ahead and open it up for some questions for Libby right now.
I do have a question here in the chat box. This is Stephanie. The question comes from Rebecca McQuaid. She'd like to know, what outcomes have you seen as a result of community relationships?
The outcomes.
Oh, no, and I'm not sure if Rebecca's still on, if she wanted to add anything. It looks like she left, but
we'll send her the answer.
Well, okay, I can just say that again, the outcomes have been extremely positive. I've been able to collect data with just the ROSOC program, which was a morphing of our original CUSOC program and ROSOC's Recovery-Oriented Systems of Care. And in that program, I was able to track a lot of changes based on working as a collaborative team and everybody being on board. Great individual data about outcomes from homelessness to housed, from no mental health services to consistent mental health, from from protracted substance use to sobriety. I mean, it was really, really exciting, and it's what's made me, as an agency director, continue to seek funding in a variety of places to keep that case management component going. Because we still have the support of the community members, even if not the financial support. So.
Great. Great. And I guess I'm wondering, what are there any other questions from folks still on the line? You must have them if you're still on the line. You're all unmuted if you'd like to ask.
They're all going, that lady talks fast.
I have one here, another one from the chat box from Janae Jasper, and she'd like to know, how do you find the homeless population when they are not using your services?
Very, very interesting. Takes us back to we have so many homeless individuals here in the agency every day that they know where the camps are, they know where people are. Interestingly enough, the night of our last point in time count, because we did it differently, everybody knew we were going to be doing surveys during the count instead of just a head count. And in the 17 camps that we went out to that we knew people were in, we only found people in one of those 17 camps. And I think that was because no one believed it was just going to be surveys. They believed that they were going to be cited for illegal camping and any other number of things. And that made it very, very difficult. So as soon as people think there's going to be law enforcement involved, everybody scatters. Having said that, as long as we know where the camps are and we only go in or have somebody who's homeless that we know go in and talk to people or bring somebody out of that camp, then we're successful.
So, Libby, it sounds like you're really using homeless individuals that do come in to help you understand where other people might be.
Exactly. They went out on the count with us, and they were very instrumental in our finding. Those were just the camps in the city of Ukiah. That wasn't, that wasn't 17 other camps outside. That was just in and around the city of Ukiah. But again, no one was there. So it really skewed this year's count. I'm sure we don't have the 2015 count. I don't think it's been completely clarified at this point. So.
All right. Well, thank you. Any other questions from folks on the line?
Thank you for having me.
Yeah, well, thank you so much for sharing information with us today about the work you've done and how you connect with folks in the rural homeless community. Like I said, we will share your slides with these slides from today with folks, and there is a whole set of slides after this one about the comprehensive assessment tool, and there's about 7 kind of tools within that tool, because it's so comprehensive, that you can take a peek at. And then if anyone has further questions about those, maybe we could ask you, Libby, if you have details for us, if there's any particular. Yeah.
And yeah, my contact info's at the very end of the, yeah.
Great. Yeah, so folks will have your contact info. And then also maybe if there are questions, we can also field them to you so that we can get the answer out to everyone, since usually it's something all folks are interested in. And thank you so much for your time today and for the great work you've done with this population, and congratulations on getting your homeless shelter up and hopefully open in November.
Exactly. Thank you.
All right. Well, thank you, everybody, for joining in, and we will be in touch with some follow-up information and items for you.
Thanks. Bye-bye.
Bye.
Thank you.